I'd like to just make a couple announcements, and then I'm going to hand the mic over to Craig Schneider to introduce our speakers for tonight. For those of you who didn't make it, we had a wonderful all-day event up in New Hampshire 2 weeks ago. Great lineup of speakers and wonderful full day of activities. Tonight is, I've been speaking with a couple people here tonight. If we don't have an event planned, we typically have an evening social, and here at Paparazzi we've been here for many years. A few people may have been thrown off by the schedule, so I just want to comment on that quickly. Tonight is a Wednesday, and in the past we probably had a few people here show up yesterday, because we've always had these events on Tuesdays. But November we are going back to our Tuesday schedule, and we'll be at the Inn at Longwood on November 17th. Please correct me if I am wrong about any of that. November 17th, please mark that down on your calendar for our next event. And then also, please mark down December 3rd, which is our annual holiday social, which is a great event to attend, and I would encourage all of you to try to make it. Believe it or not, this is already our 4th event, and this is a fiscal year, it's an academic calendar, so the 4th event already. It's really wonderful. So just want to say thank you to all the board members who are here, especially the events committee, for all the hard work putting together this event and everything else that we've done so far this year. Thank you very much. And I'd also like to make a special welcome back to Bob Dichter, who's... Welcome back, Bob. Great to have you. Bob, for those of you who know, Bob has been a long-serving member of New England Hymns and a former president of the chapter. And this summer he moved to Texas, so he's fortunately back this week on travel for work and was able to join tonight. So great to have you here again, Bob. Great to see you. All right, with that, I will shut up and hand the mic to Craig.
Oh, do you want to talk about that? Okay, later you can come admire our plaque. Yes. Scott mentioned that there was an event in New Hampshire recently, and the governor made a proclamation for health information technology. So that was nice.
All right.
So hi, good evening. I'm Craig Schneider. I'm a member of the Programs Committee and a senior researcher with Mathematica Policy Research. And I'm delighted to introduce our speakers for the evening. We're always trying to think of what would be great topics that would interest our members, and EHR implementation always rises near the surface of that list. So we have Arvind Kumar, who is a principal for electronic health record and revenue cycle management, quality and safety, and risk assurance health services at PricewaterhouseCoopers. And our other presenter is Dr. Lucinda, you go by Lucy though, right? Everett, who is the Director of Clinical Process Redesign at Partners eCare. And their topic, as you can see on the screen, is do you control your EHR or does it control you? I suspect it's the latter. So they're going to be talking about EHR risks and challenges and how to mitigate that risk. So please join me in welcoming our speakers for tonight.
Can you hear me if I don't use the mic? Oh, sorry. Okay. So somebody sent me an email and said, where did you come up with this topic? And I said, well, is it funny or is it amusing or is it insulting? And she wrote me back and said, it's pretty interesting because this is one of the vendors actually, one of the largest vendors in the HIT space. And she runs this organization and she said, we like to control our customers. I said, I know that. So with that, let me just give you a little background. I was working in the EHR, HIT space, the traditional implementation, process redesign kind of work. And I came to a very interesting place in my career to work for the Risk Management Foundation, which is the MedMal captive for Harvard medical institutions. And it opened my eyes because I saw a lot of compelling data and humbling data around patient safety and harm that could have been mitigated either through technology. There was not as much of harm that was recognized being introduced by technology, but more mitigated. And I'm not talking just looking at a lot of data, analyzing it, and then looking back and saying, could we have done something different? Something in real time. Okay? And then I had the good fortune of taking some of that data to bring back to the CIOs who were either getting ready to implement functionality, put together EHRs, or in the case of partners, they were starting their Epic journey, to bring back some of those learnings and say, where can you start addressing risks up front, right through your implementation, so that your indicators are more predictive, your indicators are more leading versus lagging indicators. Lagging indicators don't allow you to really fix something. They allow you to learn, and hopefully you don't make the mistakes again. But how do you get to leading indicators? And fortunately for us, the EHR and HIT systems, revenue cycle systems, provide us with that very rich population of data. If appropriately prioritized, looked at, you can put it either in the workflow of the provider, of the patient, the different stakeholders, and you can make a real good impact. Okay? And that's kind of where our platform is from. And I had the good fortune of working with Lucy at that time. You were taking care of the workflow part of Epic at Partners, and we put together some patient safety guides that would help them think through their configuration. So this is kind of more a discussion on what we have seen and what we're seeing in the industry and Lucy's experience, which is what you guys are really here to hear. I think this is probably the first Partners presentation on what happened with Epic. So with that, I'll kind of walk you through some background here. So we'll talk about EHR risks. I think more than who is watching you, what's coming out of the EHRs is important, but it's good to understand also who is watching you. This is what, when I joined PwC last year, I realized there's a whole slew of regulators who watch financial data. And they also regulate the way in which financial reporting is done. But there is other mechanisms to watch also clinical data and look at them from an integrated perspective, and you get a risk view. What are the challenges with EHRs? I'm not talking budgets and timelines. I'm talking really in the life of a physician, in the life of a patient. What are some of the challenges? And then how do we mitigate them? There are different approaches. There's no point in just raising the challenges and the risks, but you got to find ways to mitigate them. Why is EHR a big topic? I mean, if you look at all the investments that are going on from private equity, venture capital, they're all focused on healthcare technology. I think EHR is a kind of a proxy for healthcare information technology. I think if you look at some of these blurbs here, I won't read all of them, quality and safety, you look at value-based purchasing, you look at all the different measures that are coming out, they're looking for that transparency and quality. And I think there are 8 patient safety measures in your value-based purchasing contract that you have to meet to get that payment that's decided as being value-based, and it's supposed to be close to 40% in about 3 or 4 years. So it's an important aspect that the EHR is going to feed into. There are security challenges. If you look at it from a revenue cycle standpoint, there's almost $3.4 trillion that flows through a revenue cycle EHR kind of platform. It's a lot of money that's going through the system. There are enterprise-wide impacts to all the stakeholders. There's also issues around compliance and regulatory. So in other words, you need a good implementation, and you need to be able to sustain it. The more important part is you have to be able to sustain it. I know organizations who celebrate that they've gone live, but then they start to taper off either in their sustainability of using the technology, the tools, the processes. Something starts to fall apart. So how do you mitigate the risks around that? Here's some examples, and just to point out a few, what you see there, 350 plus regulatory compliance risks, 550 plus configuration risks, these are real stories. I brought these stories from our clients, where the clients have brought us in and said, can you participate with a risk lens in our implementation? And these are the kind of issues we flagged, where they were going to be out of compliance had they not implemented and made certain changes to their workflow content. And then there are some bad outcomes. Most of the bad outcomes you hear today are historically related to a bad AR situation or management weaknesses in the way the subledger has reported the data from a revenue cycle system to the ERP system. But those are bad events, and trying to fix them and reconfigure, it's a lot of work and it's a lot of energy. Here are some more. These to me are more material. 7% of actionable test results are never communicated to the patient. I don't know if you've seen the latest IOM study. It's all about diagnostic errors. It's all about misdiagnosis, delayed diagnosis. How does that happen? Test results don't get in the hands of patients. These are actionable test results. They don't get in the hands of the referring physician. That's a simple fix. Most systems allow you to close the loop. That's how systems are built. But we allow for this to happen. And when you show that slide to a CFO and they go, that means I'm also losing revenue. So this is not just a patient safety issue. It's also an issue around revenue, utilization, capacity. And then 75% of the med-mal claims were due to unclosed referral loops. And people look at meaningful use and say, well, doesn't that cover the gamut? Not really. It doesn't say, beyond just communicating the result back to the referring provider, make sure it gets in the provider's workflow, and make sure the provider is allowing the patient to acknowledge the result. Oh boy. The wonders of technology. Huh? So a simple act of closing the loop in a meaningful, relevant manner can improve patient safety, and it can also get you good revenues and save you money in terms of med-mal claims. Copy and paste. 20% of progress notes in critical care settings don't have the relevant information on the patient. That's a crying shame, because not only are you going to get into a fraud issue, because if you don't have the right medical necessity to support your billing, you're also causing harm to the patient. And I can go on. I mean, there's another good example of alert fatigue. One of our institutions here had 80% override experience in their clinical decision support systems. 80%. They did a study and they reduced it to 40%, okay? Because they were able to look at where the risks were, where it was meaningful, where it was relevant, and able to make that change. So just in general, I mean, here is kind of an inventory of folks who are watching what you're doing with the EHR, and that intensity with which they're watching and regulating keeps increasing. I don't know if you've seen the latest OIG regulations on copy and paste. They're getting really diligent about auditing that, okay? We know about cybersecurity, and then the list goes on. I won't read each one of these off, but there's a demand really for greater accountability, focus on governance, process, risks, designing and testing, and then monitoring. That's where the sustainability comes in. You have to be able to monitor this and make sure your guardrails that you've set up around the risks that you're trying to manage are being contained and what needs to be refined. It's a continuous process. This is kind of more or less known in the industry, a lot of failed projects, so CFOs are always constantly watching budgets, watching timelines, and here are some interesting statistics our firm kind of collects. So $78 billion a year, and this is across industries, this is not just an EHR or healthcare problem. Mostly technology projects are wasted. It's basically they either canceled, they change direction, and then if you keep going on, if you tie this out to how our EHR HIT landscape has shaped itself, I believe that less than 5% of EHR projects that are successful and sustainable have really made the mark from an on-time, on-budget. Some of them have come on-time, on-budget, but then they have had a sustainment issue. Okay? So that has to improve, and there's a risk lens you can apply to that too. So what we have done is we've taken the EHR landscape and what we have learned over the last 4 or 5 years as transitions that have gone wrong with the EHR, and we have kind of come up with like 14 categories or catalog of types of risks you're going to face, starting with patient access, revenue cycle, quality and safety, which we're going to talk to you a little bit more about with the partners example, supply chain, technology, and the list goes on. And for each of these, we've looked at these library of what can go wrong, what are the risks you can see, and how would you configure either a control, and there are 3 types of controls. There is either a control that's totally configurable, that you can put it into the system, you can bring content up, you can bring workflow up. The platform allows, most platforms will allow you to do that, okay? Or they have to do that because of meaningful use. You have to be able to create a visit summary, okay? The second type of control is a process control. Now you may sometimes have a combination of a process control and a control that relates to configuration. So you need to have a policy that says, all my critical test results will be closed. That's a process control. Now how do I make sure they're closed? Clearly the red ones get escalated. There's a middle layer, which is more the incidental findings in a critical test result. What is your policy, and how does the system allow you to track the follow-up around that incidental result, which may be a lung nodule that they may have found, has to be washed, and it shouldn't develop into something cancerous, as an example, because it's a risk. So you get a combination of process control and a configuration control. And then you have surveillance controls. You can't tell practitioners you can't use copy and paste. You can't do that. I mean, it's a utility, it's in our day-to-day lives. So you've got to monitor it. You've got to monitor it and look for guardrails. You've got to look for patterns. You've got to look for patterns where you're finding there are progress notes that are taking X amount of time in a certain specialty, and there's a subset of them that may be spending less time, but they have a higher coding incidence. It's an example, both leading to fraud-based abuse, and it could also lead to bad patient care, right? So you've got to look at these controls around these risks and make sure that you're paying attention to what really is material to your organization, what is really material to the risk threshold that you have, both as an organization and in your patient-provider relationship. There are clearly some clinical areas of focus where integrity becomes very key. I'll just kind of share with you, we've kind of classified them into loop closure, transitions of care, and unintended consequences. And they flow from referral management to population health, being able to encapsulate the data and manage the patient across an entire strata, clinical decision support, clinical documentation, medication management. Medication management is a huge challenge because there are so many gaps in how medication management across a population, across a patient's longitudinal medical record can present itself. And when you lay out the traps to make sure you're catching all the information. And in terms of orders and results, I was at a specific, very, I say, high-profile organization where the physician said, about 20 to 30% of our orders are not carried out by nursing. It's impossible to understand how you could not have that reconciliation. Not only you're putting the patient population at risk, you're also putting the ordering physician at risk. Can't allow that. So what kind of controls can you put in place? How can you manage that risk? And what is the right threshold? I don't know the answer, but I can tell you that if there is a high incidence of readmissions, for example, in a certain service line, where certain orders were not carried out, you're going to trap it. And the EHR gives you the data to do that. So you got to think along the lines of that patient-physician relationship and the care and start to prioritize where you can put the right kind of controls in place. And you know, a lot of our clinicians don't like the word control, so we sometimes use the word countermeasures. So with that, I'm going to let Lucy give us a view on the risks they manage at partners with Epic.
Thank you, Arvind. So, you know, as Arvind said, I'm involved in the Partners Project. We are obviously implementing Epic. I don't think very much of what I'm going to say here is specific to either Partners or Epic. I'm a physician, joined the Partners eCare project kind of at the beginning of it and was given responsibility for what was deemed clinical process redesign, which ended up being a lot of large processes across areas like admitting and discharge and transitions of care, and then perioperative processes and all the population health work, medication reconciliation, referral management, things like that. So I think a lot of those areas end up being complicated to manage both in the EHR and outside the EHR. Partners, I think, likes to talk about the fact that, you know, Partners has not historically been, it was a collaboration of different entities, and certainly each of them has kept their identity. And part of this project, I think at the leadership level, has felt that it's an opportunity to align the organization better and to kind of get everyone on the same page about best practices. And it's been really, I think, a good learning experience for groups to have to get together, because we've had to say to them many, many times, we're not building 5 versions of this. You know, literally, each of the partners' hospitals had taken the WHO checklist and built their own version of the surgical safety checklist, and then we had to get them together and say, which one are we going to use? And it became, you know, it went from, we couldn't possibly change what we do, to, hey, that's a really good idea that what they did at Newton Wellesley, let's add that into what we're doing at all the partners' hospitals. So I think it's really been, so people talk about it being a forcing function or being the platform that's lifting everything up, and I think it, you know, it certainly has had challenges, but it has had opportunities as well. We are currently, we went live with Revenue Cycle at Newton Wellesley and Mass General first. Brigham went live with both all at once at the end of May. And we're sort of getting ready for Mass General and Newton Wellesley clinical implementations. One of the decisions that was recently made was also to take the 2015 upgrade of Epic. We went live on the 2014 version. We're going to take the 2015 upgrade in a year from now. Partly because Epic did so many things that partners had asked for in the development that we wanted to have it, but I think people also thought it was a good opportunity to take another look at the build and standardize further. So I'm just going to talk about some clinical areas that I've encountered, and I have to, I think, start with the disclaimer that overall we think the implementation so far has gone really well. I think I'm going to emphasize some of the things that I wish I had known more about at the beginning. And I think, you know, we were talking a little bit at the table about the different vendors and different sort of strengths they bring in terms of either their physician leadership or IT. And Epic has a massive amount of experience, but the individual people that you get on your implementation may have more or less, and sometimes you have to know when to push and get the right information. But I think overall everything has gone really well. I guess my advice to people would be, you know, and there's such a big Epic community in Boston now, and people kind of talk to each other and say, well, what did you do about this? Which has been very helpful. But in general, you know, areas of concerns are really where there's not continuity in a process or communication. where it's a really complex process. I think we all said after Brigham Go Live that things we thought would be difficult were difficult. Some things that we didn't know would be difficult were also difficult, but the really complicated processes, took a lot of work beforehand and are continuing to take some refinement. Some of the specific integration risks are around data conversion from legacy data conversion, of results of things like your 10 years worth of colonoscopies. How is that going to interact with your system? Integration with legacy systems. We went from, there's a grid that shows like all the different IT systems at partners and kind of paring it down. But we didn't go to just one. There are still, some things that were left and are needing to be integrated. And I think some of that and some of the interface behavior is nuanced, and we learned on some of that as we went along. That's what's supposed to happen there. Perfect.
Yeah.
So, I like to think of it, it's not just the EHR, because we're really talking about, other systems, but we're also talking about the overlay of workflow and policy and regulatory requirements. And I think one of the other challenges can be that, you get a bunch of people, clinical end users together and talk about what their requirements are. And there may be, as Arvind pointed out, sort of risk areas or regulatory overlay that those people just don't know that much about. And they say, no, we wanted to do this, and we want to use this terminology or, whatever. So we did sort of build a governance structure in terms of a group of clinicians that make decisions at several different levels, and then liaison from compliance and from other legal and so on as we need them. But some of the high-risk areas that I thought I would call out are medication reconciliation. Arvind's talked a lot about referral management, and Craigco's done a lot of work on that. Results routing, communication of critical results, population health, and procedural sedation. We also tried to take areas where there had been work done. Partners had a lot of projects on high-performance medicine and patient affordability and so on. So we tried to take some of that structure and feed it into the EHR. So if people had done work on readmission prevention or on critical results management, we tried to take those same experts and build some of that information into the system. So I think medication reconciliation, some of the challenges that it brings up, obviously it's great now to have one list that crosses from the inpatient to outpatient spheres. I think one of the challenges it raised was that you have to decide who really owns the medication list and who's responsible for medication reconciliation. And the functionality in Epic is sort of that you can certainly go through and change each med, but you basically check off that you've reviewed the medication list. And in the legacy system, people actually were able to say, well, I'm going to reconcile these 3 medications, but not these others because I'm the cardiologist and I didn't prescribe these other meds. And so we had to sort of preach the idea that everybody's saying, every clinician that's going to touch the patient is going to say, to the best of my ability to tell, the patient's taking these medications as I've documented them. And if they're not taking them, then you have to decide, can you do something about that? Or you can do something about that in one of several ways. You can either take care of it directly yourself as a provider, or you can make sure the patient follows up with somebody that can take care of it for them. So, none of that's really EHR work, but those were the conversations we had to have around this part of the implementation. Just how the documentation beyond the basic, taking, not taking, how you document other adherence issues or communicating, the reliability of the whole medication risk were all issues we discussed as well. The other big issue for us was conversion, and so we had, I think there are pros and cons of the ease of going from, say, paper to an electronic record versus one electronic record to another. And so, there were medications already in electronic format, and we're now in a position where Brigham is live on Epic and Mass General is not yet live on Epic, and patients may be seen in both. And so we had to be concerned about the interoperability of medications. We had to be concerned about how we were going to get their med lists loaded into Epic at Go Live, and that ended up being done with a lot of CCDA creation and having staff come in ahead of the Go Live, say in the ambulatory space, to do some of this work in advance, with the idea that when clinicians were first getting used to the new system during an office visit, you wouldn't want them to also be having to transcribe the whole medication list. I think, we're looking at refining that process for Mass General. We had done, so I'm just going to show this screenshot, which you can't see very well at all, but there's the attempt to bring a lot of SIG detail in as the test patient, but and it turned out that was so, had so many constraints around what you could bring in there. We chose to bring it in for reference to the clinicians, but again, there were pros and cons of doing this versus having just, had transcribed it versus trying to do it electronically. Also making sure that, I think each time patients are seen in some other system, then we get notification in Epic that they may have outside medications to reconcile, and that's a big sort of training piece for providers as well. Moving on to referral management, and Arvind's done a lot of work on this, but the CRECO best practices really, have to do with, I sent the patient for the referral, I know that it got scheduled, I followed up if they didn't get scheduled, I got the result back. And really all the tracking you can do even on that part of the cycle doesn't take care of the follow-up piece. So, we built a report in Epic to sort of try to track those, that it's been scheduled or we've called the patient and now the appointment has actually been completed, but none of that, the phase 2 is how are we taking care of those results? So we're working on things like building a pulmonary nodule registry to track patients that need follow-up of various other items. And I think those are going to become sort of the building blocks of an ambulatory safety net to be able to follow all of those pieces through the process. Some of the other, I think one of the things that was unexpected to me was, I was familiar with referral management in this context, but in Epic, and I suspect in other systems, although I don't know it, the term referral can mean multiple things. So it can mean a provider-to-provider referral, or it can mean an authorization on the financial side. And just being able to understand that terminology and the functionality, is necessary to be able to get the right reports. And then results routing. Prior to go live, we had looked a lot at the critical results management, and because in our implementation, Epic is the ordering system and the receiving system, but a lot of the results generating areas will have their own system. So for our lab, it's SunQuest. For radiology, most of the radiologists result in a third-party system. And some of that critical results notification actually stays in the lab itself. But the piece that really I think we didn't totally appreciate was the variety of interface construction that we had in these different situations and how they all superimposed behavior on the Epic results routing system. So there's a results routing scheme in Epic that says, for an ambulatory visit, send the result to this kind of provider. But if it happens that it's an anatomic pathology result and there's only an inbound interface and the requisition went on paper and the name of the provider on paper is such and such, the lab puts it in their system and the result goes back to the wrong person. We spent a lot of time right after go live, answering, just explaining to people why they got results they weren't expecting to get. Usually they were getting a duplicate result from somebody else, but also clearly delineating in the system who has responsibility for taking action on that result. It's really important from a clinical standpoint. So, I put test. I think one of the challenges is really knowing all the things you want to test and knowing that you've got a test script that will help you really test the whole process as opposed to just, a test something you can pass. And I'm not sure I have great advice on how to define that except to really think about all the pieces of the puzzle. And then population health. We have, partners had a pretty robust population health infrastructure to begin with, but we're trying to put a lot of that, at least on the front end, into Epic. And their functionality has improved a lot over the last few years, I think. But some of the, still challenges, as I mentioned earlier, were things like your colonoscopy results and other converted results, making sure that those are going to act in the system just like a new result would act in the system. And then being able to incorporate claims data. So we're bringing a limited amount of, we did some development on top of the Epic build basically to be able to bring some claims data in to marry up and use in the clinical system. But again, the follow through on all the tests, so another piece, just like the blood nodules would be colonoscopy, it got scheduled, it got done, we know about the result, we're gonna follow up on the result. And the risk I would say is both, Arvind's got sort of the malpractice lens on it, but there's also risk in contracts of, these are performance measures that the organization's gonna be held accountable for. And if the EHR doesn't support prompting providers to do the right tests at the right time, then we're gonna lose money on that as well. And finally, procedural sedation. I'm actually an anesthesiologist, so I know this pretty well. And this is an area where the regulatory requirements for the area should make you look at it a certain way in the EHR. So when CMS or when Joint Commission or any of their other regulators come in to audit a hospital, they look at any place that gives procedural sedation as an anesthetizing location. So if nurses are giving sedation in endoscopy or in radiology, it's all considered the same from a regulatory standpoint, and you have to meet certain documentation standards at certain points of the process. And so we just tried to, they're actually kind of built in different, because there's a radiology application and a cardiology application. It's sort of duplicated in those, and we went through and just made sure that the sort of key elements of required documentation were standard across those different points. You certainly need the ability to report on the cases that were done and completion of required process steps. So this all used to be done kind of by having, the sedation nurse had to fill out a piece of paper with each case, and at Mass General, those went to a guy I know's secretary, and they sat in a cardboard box under her desk if there was nothing abnormal on them, and now we can produce a big report for that. But you do want to be able to track that they did, that all the steps were completed. I think it's also the opportunity to, I think it's an area where in terms of just training of healthcare providers, it can always use a lot of reinforcement, and one of the things we tried to do was put some of that into the build so that one of the requirements is to monitor how deeply a patient is sedated, and rather than just assume that people knew what the definitions were, we tried to put them into the tool that they're documenting in. So those are kind of some of the clinical examples I can give you from the implementation, and I think they fit back into these loop closure and transition kinds of examples, and I'll turn it back to Arvind.
Thank you. So I think one of the lessons to be taken from what we have all collectively learned, partners, Risk Management Foundation, what we see in the industry is you can actually manage the risks within the application, within the HIT tools that are available to you. You don't have to go outside and create either specific workflows outside the native application. I mean, I was surprised to see, for example, for referral management, when you start tying those 11 steps out that were laid out, this is all available in an Epic configuration. And you may have to use an You may have to use an HIE, but it's about pulling out the right reports, creating the right responsibility or work coordination, and making sure that you're able to take it through the whole loop. So every risk that you kind of want to focus on, you'll find that the tools are available. Now, having spoken about all the good things that we can manage through HIT and EHRs, it's also time to kind of start paying attention to some of the unintended consequences that you're starting to see coming out of HIT. There are patient safety organizations that have been tasked with basically collecting information on where HIT may have introduced or to some extent not performed to the level where there's an error that manifests itself. It could be due to an implementation, it could be due to design, in the way in which the software has been designed, and it could be purely just training and usability. But still, you got to bring it back to, by introducing EHR from a transformation perspective, what are you starting to see that you did not see in your paper or your pure process-driven world of patient care? So here's something Joint Commission did. It's a very small sample size, but they basically went and looked at all the RCAs, and you all know what our RCA is in the risk management world. If there is a sentinel event, or there's sometimes in some organizations, even for missed events, where there's a degree of harm that either could have been missed or was caused, you do an RCA. And if you look at things like wrong site surgery, unintended retention of a foreign body, clearly technology can help. But in many of the other areas, you found interoperability issues, okay? In terms of, for example, if you look at radiation overdose, that was caused by interoperability issues in most of the population that they looked at. And they came up with a whole list of where workflow alignment, interoperability turned out to be the biggest causes for some of these errors that they saw that led to these events. You know. And the study is available online if you want to look at it, but it puts a little different lens on how you would start looking at the use and implementation of your HIT system. Here's another study that was done by ECRI early on when meaningful use stage 1 had taken roots. And this was back in 2012. And again, a small population, but what it basically says is there were issues related to system interface, which goes back to your interoperability issues, wrong input. Now, clinicians, busy clinicians have multiple sessions open, right? And they may be going from one patient to the next in a highly dynamic setting, and they could input the information into the wrong patient session. How do you take control of that? And there are measures to do that. And there's even technology that allows you to do that. But those are the kinds of issues that started arising early on when meaningful use had taken shape. There was this large penetration from an EHR population, and people started watching these issues. There was another study that was done by the University Hospital Consortium. This kind of study caught the attention because the sample size was about 2,200 events that they were able to analyze from 40 organizations. And they used a common format of understanding where the harm took place in terms of the setting. They also were able to kind of analyze using this common format scale. They call it the ARC common format scale. What was the degree of the harm and who was involved and those kinds of issues, plus age, gender. And with that, they found that 51% of the events said there was an HIT involvement that led to this harm being done. Okay, so it's a big number. So you start to wonder what's beneath it. And they did some analysis that they shared, and your typical same types of issues that show up either because interoperability is an issue, or system performance is low. There could be some network problems, but the issues that you see are typical and they're very easy to address. Okay. Then they're either in your implementation or in your design. You can put the right kind of rigor in place and kind of address them. There were also issues that were related to the human-computer interface. This is more the usability issue. Some of it sits in training, but some of it sits in the workflow. Because what is the biggest issue physicians have from a resistance perspective in using an EHR? It's the alignment of the workflow. And it's sloppy. And they find it difficult to either capture the information intuitively or to capture the information when they're running from patient to patient. How do you make that more efficient? How do you make that more intuitive? That's going to be kind of the next push for most of these EHR systems to try to capture.
Do you mind going back a couple of
Sure.
slides to the pie chart?
I will.
I had a question. Okay, so does this say that that 51% somebody did an analysis and said HIT was part of it, and who's the reporter that HIT was involved in 4%? Why is there that difference between 51 and 4?
So the 51% is a very simple question that was answered at a topical level. Was there HIT involved in this event? And if they answered yes, that got tagged.
And who answered yes?
So that it's self-reported. So that's part of the limitation of this study.
And then the reporter is the same reporter?
Yes. So I'll take you to the limitations and then you'll see what. So the limitations were it's voluntary reporting and the categorization may not be interpreted accurately because you basically open it up to the population of risk managers across these 40 organizations, and they may not look at it from the same rigor and lens. So there are some limitations of the study. But I think the point we're trying to bring out is you have to be aware that these issues are starting to now become more transparent and are addressable. I think that's really the purpose of why ARC published this study as part of their UHC event capture and event reporting systems. Now, when we were doing some research at the Risk Management Foundation, we said, where are the areas you could point to where we think HIT risks will emerge? And this was something we put together 6-7 years ago. And I find it very interesting that when I go today and I traverse the industry, these are still the same issues. People have not addressed them. In many cases, people are not even aware that these are issues. It's starting to surface, and now they're starting to pay attention either to the configurations or the processes to make sure these risks can be addressed. It's a nice list we kind of researched with the Harvard institutions about 6-7 years ago. So having said that, how are you going to address these risks? You've got to have a disciplined process, and there are certain industry standards, especially from the financial services industry, that if you were to start applying, if you look at the 7 processes in healthcare, and then you looked at the 4 threads you see beneath them, there is controls or what I call countermeasures available from a pure process interpretation standpoint. If you take financial integrity, we all know that you've got to have patient eligibility completed to take the patient to the next level of processing a claim and to get paid for the claim, because otherwise your claim will be denied, right? So that's kind of a control that's well known. And those are prescribed in the financial aspects of healthcare organizations. Similarly, regulatory compliance, OIG puts out its plans, internal auditors put out their plans. They allow you to then segment those and see where you can put them within your configuration, where you can do surveillance to make sure you can stay within the guardrails. Technology, I mean, you've got plenty of regulators watching the cybersecurity space. There's plenty of regulation that you could follow, and you could actually embed it in your footprint to make sure you've got the right kind of security, hygiene in your perimeter. And now, of course, there's also the issue around segregation of duty. You don't want to have toxic relationships where somebody can process an order and also pay for it, or process the authorization for payment. So we know that these 3 threads, they're well articulated, they've evolved. The thread that's still not got the attention, I think, of providers, and now we can do that because EHRs allow you to do that, is really around patient safety and clinical quality. And our guidance would be, start doing that when you start planning your implementation. Now, many of you have completed your implementations, there's still an opportunity to go back. The opportunity may not be that great because it's very hard to change certain workflows, configurations, and habits, but you can at least understand where you've got gaps and try to close them out with process controls or other types of mitigation strategies. So that's kind of what we had planned to share with you today, and we'll take any questions you'd like to kind of ask me or Lucy, and we'll give you a perspective. Sure.
I'm Pat Rio from Elsevier Clinical Solutions, and I'm curious to know this new emphasis we're seeing on the EHR companies coming together to work on interoperability. Has this been a catalyst to get them to that point, or was this just part of the evolution? Does this resonate with the EHR vendors?
It resonates with the EHR vendors, but it doesn't get their attention as yet.
Shucks.
You have Lucy, you've gone through a recent Epic implementation. What was their reaction to when you brought up safety-related issues? Epic would.
Well, I think, I'm not sure that's her question, though. I mean, in terms of, but I think in terms of, when we pointed out safety risks, I think they tried very hard to, to help us solve them. You always have to distinguish what's the safety risk because of the software and what's the risk because of what you're doing with it. And so.
And users have a nice way of saying any change they want is related to safety. I think I saw somebody here from Atrius.
Yeah.
They've got a swim lane concept to really manage that. Everything is not safety related, so
Yeah, but
don't
it might
buy
get
both.
worked on quicker if you say that.
That's how it starts. Yeah. Go ahead.
So you've done an excellent job of describing the problem. How about any success stories about achieving reduction?
So I can tell you one success story that I know has evolved is referral management within the Harvard institutions for certain critical areas now have full loop closure. And I'm talking BIDMC, Atrius, partners, all of them. So there is some success. It took about 3 years to get there. That's a different issue.
And what did it cost?
I can share that with you, Ethan.
But that was through Krakow RMF?
Yes. Absolutely.
So one of the risks that I don't think you're talking about is that there's a really high rate of physician burnout with EHR implementations. And that's a really big issue. And it's a combination workflow, design, and the design is kind of an afterthought instead of a forethought. So how is